Okay, we're live. Hey, everybody. Welcome. We're getting in here really quick. Welcome to a special Friday edition of Kicking It with Kerry with Dr. Lamer. We'll make sure Dr. Lamer, did I just say Dr. Lamer? This is not Dr. Lamer. This is Dr. Robin Lewallen, board certified dermatologist. We're going to be talking today about psoriasis, something that affects so many people. Tell me a little bit about who gets affected by psoriasis and, what the things we can do to help them.
Yeah, so psoriasis, I think, is about 3% of the U.S. population has psoriasis, so it's a very large portion. But that's the portion of people that actually seek care for it. So there's probably a lot of people that have like little flaky patches or things like that that never come in. So the rate's probably higher than 3% of the U.S. population. And it is a genetic condition as well, so it does run in families. There's what we call...
Close the door here. Keep going.
Yeah, there's what we call a bimodal distribution of people that get psoriasis. So it's really common for people to get diagnosed with it like a teenage time.
Okay.
Or in their 40, 50 age range. So it's common to get even a genetic disease to be diagnosed later, which most people don't really feel like that's the case, but it's common to get newly diagnosed with psoriasis even in your 30s, 40s, 50s.
I smirked and she saw it, but you guys didn't because I'm facing the wrong direction because I kept doing this and I had this sort of little, itchy little sort of patch spot. And
do we need to do a skin check on you after this?
No, I think you already told me I had psoriasis. So a little bit of cream.
Yeah, so it depends on the location as to where or what treatment we do, and the amount that you have. So psoriasis, when you think about it, most people have it on the scalp. Some people get it on elbows, knees, belly button area, kind of the upper part of the buttock is a really common location too. And that's common for plaque psoriasis, or kind of those larger patches that people see. And then there's other variants of psoriasis too. So you can have gut-type psoriasis, which is kind of all over, and gut-type means coins, so it's a bunch of little small ones.
Okay.
And that would be really hard to treat with cream, for example.
Yeah.
As opposed to a little patch on the scalp or on the elbow would be easy to treat with creams.
Right. Okay, so if you're just joining us, we're talking about psoriasis. Dr. Lewallen has told us that 3% of the population is diagnosed with psoriasis, but many others go undiagnosed because it's just sort of like a little irritating thing that many people just live with and maybe don't even realize that there's a solution for. So we discussed that some can be, it's not curable.
Correct.
You're always going to have it. It's going to recur under instances of stress, or why does it recur? Why does it come and go?
Yeah, so we don't really have a great idea of why it comes to go. Stress would be one reason why it might. It tends to be treated by sun. So in this area, we have people that come in more in the winter time, where they're wearing clothes that are covering, and then they're not getting sun on their arms or face anymore, and then they'll get more active disease during that time.
Okay.
So sometimes it's just seasonally related, stress related. But genetics probably plays the biggest role in that.
Can it be harmful? Is it dangerous? Can you die from psoriasis?
So it can be harmful.
Okay.
I've never heard of anyone dying from psoriasis, but you can have what's called erythrodermic psoriasis, and that's where psoriasis affects more than 90% of your body surface area.
Okay.
And in that sense, you can actually lose so many skin cells that you get nutritionally depleted, or you have heat cold intolerance, and a lot of those people can be hospitalized for that. So it can be serious as well.
I had no idea.
Yeah.
I did not know that. Good to know.
Yeah, joke question, but it can actually be really serious. So it can affect so much of the body that it can be something that you have to be hospitalized for.
I wasn't really joking. I just kind of I was, being the lay person and just asking kind of
how serious can it be?
How serious can it be? So I imagine that's very uncommon for it to get to that stage.
It's uncommon to have it to that degree. We consider psoriasis severe when it affects more than 10% of your body surface area. And then, for example, what a percent is, the size of your palm is 1%.
Okay.
So if you have more than 10 palms worth of psoriasis, you're considered severe. And that opens different treatments that you would kind of qualify for.
So what, other than the cream that I mentioned, what other treatments are there?
Yeah, so if you have less than 10% body surface area, a lot of times we'll do creams. If you have more than 10%, or if it's an area that's like really bothersome, like for example, if it's 1% of your sole of your foot, that can be debilitating and you can't walk. So you would still qualify for more intensive treatment in that case.
Yeah.
So if you have that 10% or special site involvement, then you would qualify for injectable therapies, which I have a couple here, or some pills or other kinds of treatments.
Okay. So since most of our audience is probably the mild cases, I want to just cover a little bit more on that real quick. So you mentioned that you could have it in, you said top of the buttocks, elbows, scalp. When it's in the scalp, I think that's probably, is that the most common?
The scalp to me is the most common that I see because it's kind of like a cousin to dandruff. Like, do you have just dandruff, which we medically call dandruff seborrheic dermatitis, or do you have it more severe where it's psoriasis? So they're on like a spectrum between those two.
And how do you tell? Is it just like how much is bothering you, or is it?
So it's the way it looks clinically is how I tell. So you actually would need to go to a physician and have it evaluated and looked at, and then we can tell based on like the way that the shape of it is or the thickness of what you're growing on the scalp and all of that would be able to tell.
And if you've been just thinking it's dandruff and buying the Head and Shoulders, is that going to help?
So Head and Shoulders, it does have the active ingredient zinc parathione, and zinc parathione does help with psoriasis as well, but you might need just more than that to get it better.
Okay.
Yeah, so it would help, but probably not all the way to where you're clear.
You should probably come and see us if you're, kind of suffering or struggling or even just annoyed by some thickening of plaque on your scalp. You should come see us, get a prescription. So let's talk about the more serious cases that might require an injectable treatment. What do we have for those people?
I have just for the mild people. I brought some things that we have here too.
Where?
That can go in that little
in the
bag.
I'm like looking at the tray. Okay, let's talk about these things.
Yeah. So for more mild disease, so Head and Shoulders would be like zinc parathione active ingredient. This one's salicylic acid, so it really helps with people that have flaking at the scalp. So this one would be good for people that have a lot of flaking. It would help with dandruff, but also like flaky psoriasis patches.
So we have this in our product store. It's a CLN, shampoo, and that is available in our store, on our website. And can you buy this at CVS?
No.
You can't buy this at CVS. So you
I
have to
believe
come
you could
see
probably
us.
buy it online elsewhere, but I don't know about if it would be the actual.
You don't know if it's the actual one. So if you want the real thing, come to our office. What else do we have that can help with that?
Yeah, so some people that have kind of facial involvement, like eyebrows and nose area, again, that's kind of an overlap between the dandruff of the face versus do you have psoriasis. This could be something that would be good to try for that. And this one you can get just over the counter, but we do have it here.
So many people call and say, I have flaking on my eyelid. Is that psoriasis?
It could be, yeah. So you can have flaking of the eyelid or eyebrow area, and it could be psoriasis. We'd have to kind of look and see, but
once again, you got to come in and see
eczema
us.
It
could be any number of things. But you guys, I mentioned that one. I answer the phones here a lot, and so many people are like, I've got this, like dryness on my eyelid. It's bothering me. I can't get rid of it. Such an easy fix if you just come in and get it diagnosed, okay? And it's usually a prescription cream, and it's treatable, okay? So please come in. Next, what else do we have?
Yeah, these are kind of more on the same line. So people that have kind of the bigger plaque type psoriasis, like elbows, knees, hands, feet, or somewhere on the body. I like doing these before the prescription creams because it helps with penetration of the medicine into those thick areas of skin.
Okay, and these are our acne clearing toning pads. So that does make a lot of sense. You're going to just get a real nice, clean, absorbable surface for the medication to work a little bit better.
So you would kind of, even though it says acne, you would kind of wipe, like if you had elbow psoriasis, you would wipe that wipe onto the area first, and then wait for it to dry, and then you would put your medication on. So it'd get rid of some of the thick flaking skin that you see in psoriasis, and then allow the medicine to work a little better.
Would that also be true for people who have scalp psoriasis to kind of use that on, like if they're bald? I'm picturing like balding men. Yeah, not me with my hair.
Maybe the salicylic shampoo would be better for most people, but if you were a bald man, then you could certainly do like the salicylic acid.
Okay, and then what do we have here?
Yeah, so this one I love for like People have hand and foot psoriasis where it's really thick and hard to treat. Sometimes it's hand-foot eczema or psoriasis. This one has urea, and urea really helps to exfoliate thickened skin. So that one would be good for pre-treatment too.
Awesome. So pre-treat with these products, and then apply the medicated ointment or cream.
Exactly. And then there's 3 common medications for kind of mild disease. There's steroids, which probably most people that have psoriasis have gotten like a topical steroid to use. There's topical vitamin D analogs, which are called calcipotriene.
Okay.
So that would be something else that we use, usually for like long-term maintenance. Like if you know you always get it on your elbows, you would treat with the steroid for 2 weeks or so, more or less, until it clears. And then you could use the vitamin D to kind of keep it at bay.
Because you don't want to use steroids
Long-term on normal skin because it can thin it down. Our goal with psoriasis and doing a steroid is actually that side effect to happen. You want the psoriasis to thin down. So
right.
That's the treatment goal, is to cause thinning. But you don't want to, once it's normal, keep applying that because it will start to thin down your normal skin.
Right, right.
Yeah, so the vitamin D analog, or calcipotriene is its name, helps with that. The branded name for that's Dovanex. And then the third one that is approved for psoriasis is retinol.
Really?
Yeah, so people use like something like Tazorac or Tazarotene, and that helps to thin it down again, like we said, and really helps with kind of steroid penetration, or it's really common to use on like hand and feet psoriasis. So using
so many
like
useful uses for retinoids.
I
mean, right?
Yeah, it helps almost anything.
That's amazing. That's good stuff. Okay. So then these more serious cases, people who have it over more than 10% of their body, or in a very troublesome place like their feet.
Yeah, or like bunches of little ones where you can't really apply cream to all that, or it'd take all day.
Yeah.
Usually the next step up that people consider would be doing narrowband UVB or light therapy. So there's a certain wavelength of light that's proven to help with psoriasis. It's anti-inflammatory. I only do that in people that don't have like a personal or family history of skin cancer, because it does increase your risk of skin cancer. But that would kind of be next step up.
Okay.
Or doing something like Otezla, which is a tablet for psoriasis. So Otezla, it's actually not an immunosuppressant. It's actually an immunomodulator, so it doesn't make you more prone to infections.
Okay.
This one's nice because you don't have to do lab monitoring with it. Main side effect is GI intolerance.
Is this kind of new?
This one's been around for, I mean, at least 7 to 10 years. It's been around for a while.
All right.
Yeah, I think it's kind of new that our office is doing it a lot more. With me coming on and then Dr. Limmer coming on, we do a lot more Otezla. Just because it doesn't require any lab monitoring, it's very safe. So usually I'll have people try this one first to see how it goes.
And hope that works.
And hope that works, because it's very safe.
Yes.
Very safe. And because of the GI side effects, sometimes it causes weight loss, which people like as a side effect.
Can I take it?
So as far as the side effect for it does have some GI intolerance, but it also has some benefit from that too.
Right.
So you get weight loss.
Okay, and then this other one, Cocentix.
Yeah, so I mostly brought this one not necessarily to like promote Cocentix at all, but it's one of the injectable biologics. So that's like a whole family of medicines that we use for psoriasis. So if you have greater than 10% body surface area and we're not able to clear it up, or you have one of those special sites that really affects your daily life, like facial involvement, hands and feet, groin is a special site. So if you have that, then sometimes we'll do an injectable biologic. So these are large molecules that bind to the inflammation in the skin and what's circulating in the body.
Okay.
So psoriasis is actually not just a skin disorder. There's inflammatory cells circulating throughout the body. People with psoriasis actually have increased risk of heart disease because of that. So a lot of people that have more extensive involvement, it's good to treat it because that might reduce your risk of heart attacks, heart disease, and other things too.
And this is, we did another video with Dr. Lewallen. If you're watching this and you're like, oh my gosh, that's me, and I didn't know that I had this. Remember when we did the injection, we showed you injecting one of our medical assistants.
A little different than it wasn't Cocentix. That one was actually Dupixent.
Okay.
And that one's for eczema.
Oh, okay. So that was a whole different thing.
But that one is like an injectable biologic, and so we can do eczema maybe next week or
what's the difference between psoriasis and eczema?
Yeah. So completely different genetics and completely different inflammatory markers that are circulating. And then psoriasis, like in the basics of it, is thickened skin, and eczema is a skin barrier breakdown, so it's like thinner skin that's broken open.
Okay.
Yeah. So in like the basic,
that's all these guys
that's
need.
all
we don't want to get too crazy.
Psoriasis, thickened skin. That's why we have to try to thin it down as much as possible. Eczema is all about rebuilding the skin barrier, putting moisturizers on, and like trying to repair and restore what's missing. Whereas this is trying to get rid of something.
Got it. Okay, so for most of the people that are probably watching, they probably have mild cases. So I guess, the word would be get diagnosed. We have some like over-the-counter non-prescription things to start with, and then we've got some, stronger prescription things. So don't be out there suffering, you guys. Give us a call. Dr. Lewallen's here with us Wednesdays and Fridays. She would love to see you. Do you have anything that we didn't cover? Anything else you want to add?
No, I think that one kind of unique thing about our practice is not a lot of practices do biologics in the area. So I think that that's another kind of unique thing that our office does offer that is a benefit to the community.
Absolutely. Yeah, I know. It's good stuff. So thank you guys for joining us so much. Thank you, Dr. Lewallen. I appreciate you taking the time out on your busy Friday. And we look forward to seeing you again next time. Maybe next, week or two, we'll talk about eczema. Bye, guys.
Bye.
I gotta put my glasses on to turn this off.
I like we need to get like a young